Welcome back, everybody. Our next session is going to be great. State of the PIVC address. I'm honored to introduce you to Stephanie Pitts and David Benko. Now, Stephanie is a fixture to AVA, but her partner for this presentation is new to us, and we rarely get a CPA joining our AVA family. Here's a little bit about Dave. Now, remember, their full bios are listed on the conference website. Dave is Director of Health Economics and Outcomes Research at B. Braun Medical Incorporated. He's responsible for identifying strategies to leverage health economics and outcome studies. And without further ado, let's get right to it. Stephanie and Dave, it's all yours.
Judy, thank you so much for that introduction and for the opportunity to be with all of you today. Good day, good morning, good afternoon, good evening to some. Dave and I have the opportunity to work on a really unique team. And by design, we often disagree with how we view the healthcare market. I may have a clinical idea. Dave sometimes will challenge me with, well, how much does that cost? What does that look like from a financial standpoint? And the reason we wanted to co-present with you today is often as you're making decisions and working through challenges in your organizations, you're challenged with the same thing. So you'll get the opportunity to have me present representing the clinical side, and Dave, often known as our in-house bean counter. With that, these are our financial disclosures. Today, we're super excited to talk through some of the key trends, recent literature related to peripheral IV catheters. We're going to walk you through policies that are impacting our care today related to insertion, care, and maintenance of peripheral IVs. We're going to talk about the implications of recent publications to our practice. And we're going to discuss some preliminary results of a real-world peripheral IV improvement program. But to get started, I just want to ask you a couple of fun questions. What if it took the barista at the local coffee shop 2 to 3 tries to get your coffee right? What if less than 57% of the drivers today in your town had never received any driving education? I can't help but think of those of you in Los Angeles, New York City, or Atlanta. That's quite frightening. As many of us have worked significantly online, especially over the last year and a half, what if our internet stopped working 70% of the time while we were online? And I ask you, would any of these real-world challenges or complications be acceptable? Let's translate those similar statistics to peripheral IV catheter facts. Today, the majority of our hospitalized patients receive a peripheral IV catheter throughout their hospital stay. But less than 57% of nursing students today receive any instruction. And unfortunately, up to 69% of IVs fail before the completion of treatment. Dave would tell us and would want us to also realize these complications cost our healthcare system a lot of money. Complication costs are estimated to be up to $121,000 for a 250-bed hospital. Interestingly, we have identified a lot of these complications as acceptable, and I'll share with you throughout the remainder of these slides why. But the gentleman himself who said they're unacceptable is Dr. Robert Helm. I did something kind of random and bold that I'd never done before. I've cited Dr. Helm's work so much over the last few years, and I randomly sent him an email. I said, "Dear Dr. Helm, I would love the opportunity to talk to you and understand why, as a cardiac surgeon, you care enough about peripheral IV catheters to research and write about them." And my conversation with him, he replied to my email, which I was even more excited about. I had the opportunity to have a conversation with him, and it was so compelling that it only seemed right to share his viewpoint with you. So with that, I'd like to share with you a brief piece of the interview that I had with Dr. Helm. Dr. Helm, thank you so much for joining me today. I just have a couple of really basic questions that I want to ask you. So one, you're a cardiac surgeon. Why are IVs important to you?
That's a really good question. I've asked myself that sometimes. I think the bottom line, it comes down to cardiac surgery requires complete optimization of the system that you apply to the patient. So every single detail must be perfect to get a good outcome. And so when I even tell each of my patients, I say, all I'm going to do, and I treat everybody exactly the same, is I'm going to do each individual step as efficiently and perfectly as I can in the correct logical sequence, and that should give us a very highly reproducible result, and that result should be the most perfect result that I can do, and I can only promise you that that's what I will do. And so that's how I look at doing heart surgery. And what started me with IV catheters is I've always seen the number of failures, throughout medical school and residency and cardiac surgery fellowship, and then as a practicing surgeon. And it was always something where they would fail, we would just replace them. And it was just part of the process. But then I had several patients that I had to cancel in a row because they were transferred in and they had infected IV sites. And I just began to say, okay, well, that's one part of the system. Let's try to optimize that system. I started to look at it, and as I looked into it more and more, I began to realize, wow, the failure rate's really high. The rate of phlebitis and all the different mechanisms. And that's what my research on that, just trying to understand it so that then I could fix that part of my own system, because it is a part of my system. I'm taking care of the patient. The peripheral IV is in every single patient. It's an important part of me caring for that patient. So in trying to optimize that, I began to understand that there's this problem that's totally, completely unacceptable, but fully accepted. It's just how it is. And that prompted the paper. And that's why I'm still working on it today to try to figure out how to solve this problem. And I do think it's solvable.
If there's one thing that you could say to this audience related to peripheral IVs that we really need to focus on, what would you recommend?
Well, just like heart surgery, it's not any one thing. I would say it's doing everything perfectly in the correct logical sequence. For example, there should only be one stick at the perfect site in the best possible vein. The only way to do that is to use vein localization technology. I feel that when you grasp that catheter, when you touch anything, it should be done with sterile gloves, and there should be a localized sterile field. So those are two things. And then when you place the IV catheter, it should be stabilized, and there's devices to do that. Should you put a biopatch on? Well, if you've used sterile gloves and if you've prepped the skin correctly, you don't need that. But if they stay in longer, maybe that is something you should do. But are there other ways to do that with the dressing themselves, with integrated dressings?
So with this audience, these vascular access, let's say they're influencers in their facilities, how can we be the voice in making the accepted unacceptable?
Excellent question, and I've thought about that a lot. How do you institute change when something has been accepted for so long and it's shown resistance to improvement despite attempts? There's a lot of really smart, really good people that care about this, and yet it's kind of still there in the 30 to 50% range. And so I think the one thing that could really help is, instead of just pulling out a failed IV, throwing it out and starting another one, take that IV and consider that a little piece of gold, a little piece of getting to the solution, and send it for culture, or at least record the fact that it failed, because most hospitals don't. I think the most important thing that we can do to affect change is to reveal the true inadequacy of what's happening. If the airline industry, the food processing industry, the automobile industry had a failure rate that was a fraction of 50%, it would be a huge problem. because people see it. They would see it. There'd be death and everything else. And even though IV catheters don't have that endpoint, although they can, I think if we can depict what's actually happening in a strong enough way that is perceived adversely to the public, we can affect change. But it's going to start with simply collecting that data.
Thank you, Dr. Helm, for sharing your perspective with all of us here at this conference. I can't help but hang on to the fact that here's a man who is performing heart surgeries in the morning and talking to me about peripheral IVs in the afternoon because he cares so much about that component of his process and about patient outcomes and patient safety. With that, I want to ask you a question. You've got in front of you two pictures. I would like you to think about what is the similarity between cicadas and research. I know many of you, especially here in the United States, were challenged with the cicada problem this year. Thankfully, in Florida, we have enough other bugs. We didn't have cicadas, but I really enjoyed watching the news and the information about cicadas. Well, I'll give you the answer. Cicadas spend the first 17 years of their life burrowed in the ground. They're not just down there sleeping, they're actually really busy. They're feeding, they're moving around, they're doing a lot of movement. And when they emerge, they live for a few weeks, long enough to mate, fertilize the eggs, and start the life cycle all over again. Really great, right? How does this relate to research? Evidence demonstrates that it takes 17 years to translate evidence into practice. It's too long. And it's why we're all here as specialists in our field to shorten that time period, to get the evidence that we know is happening today to patient care faster. I'd like to also identify that when it comes to peripheral IV catheters, what we aren't taught might be hurting our patients. We have some amazing members within the AVA organization that have published some excellent articles on this topic. Dr. Vanden Hooten, Andrea Owens, Judy Thompson, Mark Hunter have done research and published on the lack of peripheral IV catheter education, not only in schools, but in our hospitals. Not only the lack of, but the inconsistency of education and training. This simple lack in our field might be hurting our patients, and it has to be addressed. There are a lot of activities currently underway to address that, specifically related to schools, but we also have a huge opportunity to address the lack of education in our hospitals as well. I can't help but translate that lack of education to the big announcement that we had this year from ECRI when they named peripheral vascular harm to the top 10 patient safety concern list. I have to say I was somewhat excited, but more so sad to see this listed here this year. Just for reference, peripheral IVs were also listed in 2019. Excited because we have a lot of opportunity to improve, but sad because it's not happening fast enough. What did they say? First of all, ECRI identified that peripheral IV catheters are the most widely used invasive devices amongst inpatients in healthcare today. Up to 69% of IVs are failing before the completion of treatment. These statistics are going to ring and sound familiar. In the ECRI database, they analyzed over 27,000 peripheral IV catheter events, and they found that over 6,000 of these events were related to infections, and 21,000 were non-infectious harmful events to patients. And they also identified that our patients are getting stuck entirely too many times. And I would argue to say that ECRI said this is unacceptable, which is why it made it to the list. They went on in their report to identify action recommendations. These recommendations include continuous education and training, monitoring and auditing of care and practice and outcomes, the use of visualization technology, limiting the number of sticks that our patients experience. And what's really fascinating about all of these recommendations is it's not anything new. We also see all of these same recommendations in our most recent publication of the INS standards published in January of this year. What's interesting about these recommendations and standards is the viewpoint of our healthcare leaders today. Dr. Lynn Soban, a nursing researcher, did some preliminary, I would say a small group research, understanding nurse leader perspective. She interviewed 8 respondents, 8 individuals across 6 hospitals, 5 different health systems in 4 different states. These were chief nursing officers, assistant CNOs, nurse executives, VPs, nursing directors, quality and safety, and managers of vascular access teams. She talked to them on the topics of vein visualization, policy, and data. And I'll share at a high level some of these results. So across the 6 institutions where interviews were conducted, only 2 had formal escalation plans for difficult IV access. Only 2. I would argue there are a lot of difficult IV access patients coming into our healthcare institutions today. And quite sad is barely one institution was actually collecting any data at all on peripheral IV catheters. They were collecting specifically really harmful outcomes in their risk management reporting system and had a process in place to understand those. The rest of the organizations weren't collecting specific IV catheter data. With that, I'd like you to get your phone. I'm sure it's nearby. I'd like you to get a little closer and get ready to participate in the poll that will be coming up. When you go in to your phone, you're going to go to your text message tab and start a new message. You're going to text that message to 22333, and the response to the poll will be entered where you would enter a message. Here's the poll question. Which one of these potential outcomes of implementing a comprehensive peripheral IV program do you think most accurately reflects your organization's priorities? The answers there are on your screen, and I would ask you to text the number next to your response in the message. Is your organization's priority to decrease the number of IV insertion attempts? Increase your nurses' confidence related to IV insertion? Increase peripheral IV dwell times and inpatient satisfaction? Decrease your overall peripheral IV catheter insertion cost? Or decrease overall complications? I'll give you a moment of silence for you to respond. You guys are awake this morning. This is looking great. Thank you for participating. Dave, there's some people in the audience that care about cost. I know you're going to be excited.
I'm saying that, yes.
All right. Just a little bit more time to respond. Thank you for participating. This is great. All right, with that, it appears very obvious that the front winner here, this reminds me of the Olympics. We were just watching all the runners or the swimmers in the lanes. It looks like based on this audience poll that the opportunity to improve the peripheral IV patient experience and patient satisfaction is really key and really important to our audience, followed by the opportunity to improve first stick success. Dave, I'm glad that you're here, and it does look like there are members in our audience that also care about the opportunity to reduce overall cost.
Yeah, much appreciated from the bean counter side. We realize certainly from the Sisters of Mercy, no margin, no mission. So we want to do everything we can for the patient, but we also want to be able to care for that next patient coming through the door as well. So great poll results here, certainly. And I do appreciate the nod on the cost side.
Let's see. So here we've identified your majority of responses are related to patient satisfaction, followed by overall first stick success. Let's see how your results compared. We sent the same question out a few months back via an email survey, and we asked the respondents which one of these potential outcomes was important to them. And the response that we received was really strong, especially from the vascular access group, related to the number of IV insertion attempts. What's interesting is when we broke out the responses and understood what was important to our nurse executives, our nursing leaders, our CNOs, it had to do with patient satisfaction. I think the point of this message and the point of this poll is that it's really important as vascular access clinicians that we're directly aligned with the goals of our organization and our nursing leaders. We know first stick success has a direct connection to patient satisfaction. So it's just important that as we implement initiatives in our organization, that we're walking in step with our nursing leaders. Thank you for participating in the poll. With that, I'd like to go back to talking about Dr. Helm's publication. In his accepted but unacceptable publication, he revealed the most common causes of IV failures succinctly, with infiltration trumping at 23.9%, followed by occlusion and mechanical failure at 18%, phlebitis at 15%, dislodgement near 7%, and catheter-related bloodstream infection at 0.2%. When we take the most common causes of failure and we align them with modifiable factors like the peripheral IV site, the catheter size, how a catheter is secured, and the compliance to aseptic technique, we might ask ourselves if these complications might be preventable through these modifiable factors. There was a recent publication, and it came out just a few weeks ago, so it wasn't enough time for us to include it in the presentation, but it challenged all the modifiable factors and said perhaps it's the device. And I would argue that it's all of it. We have an opportunity as healthcare providers to continue to monitor and track our progress. And on the industry side, we have an opportunity to continue to innovate. When ECRI published the top 10 patient safety report, part of what pushed that to get onto the list was the peripheral IV catheter events that get reported into their PSO. They had over 27,000 peripheral IV catheter events. And you can see here 22% of those were infectious and 78% of those complication events were non-infectious. So I want to just take a second and identify that these complications are underreported and arguably undermining patient safety today. When we think about peripheral IV catheter infection risk, and this happens to be the arm of a loved one of mine, there are really 4 key areas that we identify infection risk to occur related to a peripheral IV. One is actually through the insertion site. When we take that needle and poke through the skin and into the vessel, that's a primary opportunity for infection. Additionally, the catheter hub. We all watch, all of our healthcare providers, ourselves included, our ICU nurses, anesthesia, the OR, frequently go in and out of the hubs of our catheters. We all recognize that's an infection risk as well, along with bacteria that's circulating in the blood and the potential for contaminants within the infusate. We have a huge opportunity to continue to raise awareness around peripheral IV catheter infections within our organization, but it starts with understanding, preventing, and measuring them. Dr. Tripathi or Taylor Gladfelter, if you happen to be in the audience, thank you for your amazing publication this year where you did a retrospective review of over 44,000 adult and pediatric patients with a peripheral IV catheter. In the publication by Tripathi and Gladfelter, they identified that the average dwell time for an adult peripheral IV was 2.6 days, and in children it was 2.8 days. The failure rates in adults were 76% and in children 56%. Arguably, with the pediatric population, just for the audience perspective, they identified that often pediatric IVs are super secured to help protect them, which might be why they had a little bit longer of a dwell time. But when we look at how this compares to the average length of stay of our adult and pediatric patients, we're not hitting the mark. For the average adult patient, their inpatient stay is about 4.6 days. And in kids, it's about 4 days, depending on their age. RIV catheters are not lasting for their length of their admission. This should be our guiding star. This should be our organizational goal. Diving a little bit deeper into this publication and peeling out the pediatric data and only looking at the adult data, it reveals that in this population studied, 26% of their patients only had one IV catheter. Now, these are indwelling catheters. So this isn't the amount of attempts. This is actually indwelling. 54% of their patients had 2 to 4 catheters. 16% had 5 to 9 catheters. And 3% had over 10. And some of us sometimes blow off the small percentage there, that 3%, but that was over 2,000 patients. That's our family members, our community members, our friends, our loved ones. Every one of these statistics is a human being. That might be our own family. And I think it's more compelling when you summarize this data to recognize that 1 in 5 adults required more than 5 IV catheters per admission. While that is compelling enough, I can't help but ask and wonder, how many total times were these patients stuck during their hospitalization? How many pinholes were created in their arms? Have your phones nearby. We have another poll that's coming up. Again, you'll text to 22333. And here's the question. Does your organization currently collect data on the proportion of peripheral IV catheter insertions achieved on the first stick? Yes, no, or you are not sure. I'll give you just a few moments to respond. So does your organization currently collect data on the proportion of IV insertions achieved on first stick success? Thank you for participating. This is great. If you haven't responded yet, you got a few more seconds to get it in there. All right, it looks like what I'm seeing so far is that the majority of the responses here, right now we're at 70% are not collecting first stick success, 16% are sure. There's a few organizations that are, which is excellent. 72% are not, 14% not sure. 70% are not, 14% not sure. 72% 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 are not, 14 Excellent. All right. I think this wraps up this survey question.
Hey, Stephanie, I would like to add something there.
Sure. Thanks, Dave.
Yeah, so what's very interesting about the results is if we had phrased the question slightly different and asking if their electronic health record had fields to then chart for all these data. What we found out in our experience is that the fields are already built, there's an interest in it, but given all of the competing priorities for that nurse, those fields are not being completed, as well as compliance from the hospital, right? The hospital's not mandating that they be completed. That was a pathway that we initially thought is, hey, let's just review the electronic health record to see what's happening, and those data are not available.
Dave, that's an amazing point. I think myself as a vascular access nurse can relate. Oftentimes we get a call to a patient and, the message might come through an EMR order that says patient's been stuck multiple times, unsuccessful. And we get there and we go to document and there's no documentation of any attempts. So you bring about a good point. And I know in my organization, it's not a force field. So it's not a mandatory field to be documented in. So it's something we're supposed to document in, but it's not mandatory. So thank you for making that point. We also took this audience poll question and we did a pre-survey prior to this AVA meeting. And I have to tell you, your responses aligned with the responses that we received as well. Majority of our organizations today have really no idea what their first stick success even looks like. And I have to say that when I look back at I'm going to call it the timeline of attempts, the year I graduated nursing school was 1998. I'm aging myself here a little bit. And when we look back to the literature in 1998, our first attempt success rate was over 2. And as I've scoured the literature over the years, there's various reporting, various studies, and I've only pulled a few here, but it's consistent. You can see in 2012, it was over 2 attempts. In 2017, they identified an average of over 5 attempts. And in 2020, we continue to be at an attempt rate of over 2. And I have to tell you guys, and I'm a little competitive, but the market reports, which do predict what's happening in healthcare over the years, all the way into 2025, they're not showing us getting any better. I take that personally. And I know when we look at ourselves and each other as AVA members, oftentimes we're the best in our institutions, but we're not touching every patient that gets an IV in our institution. And I can't help but acknowledge the fact that while I may not blind stick, the majority of healthcare providers today do. They essentially have a blindfold. And while I'm so thankful that we wear gloves because we're all protected and we need to be, I have identified that when I palpate through a gloved hand using ultrasound, I cannot feel a vein that's more than 0.5 centimeter below the skin. Now, everybody's feeler might be different, but that's been my assessment. So we need to continue to wear gloves, but we need to incorporate and eliminate blind sticking. Going back to the survey that Dr. Lynn Soban conducted this past spring with these 8 nursing leaders across 6 institutions, she asked them, what is the availability of visualization technology in your organization? And 4 identified they have it. But only 2 of the 6 organizations identified that they routinely use it with their staff nurses. I don't think that this is going to change until we drive policy change. And what helps us to drive policy change is standards of practice. The INS standards from this year, in fact, 22.1, state that vascular visualization technology is employed to increase insertion success of the most appropriate, least invasive access devices, minimizing the need to escalate to an unnecessary, more invasive device, and to reduce insertion-related complications. Furthermore, in a position paper published by Matt Ostroff and myself, we identified that technology, coupled with skilled clinician, offers patients a safer, more reliable, and less invasive solution for achieving vascular access. What drives your organization's policy change should be these standards of practice. You have the information and the documentation in front of you to help drive that change in your organization, and I would encourage you to do so. As we sit in a conference like AVA, we often think, yeah, I want this in my institution. If you think someone else is going to drive that change, you might be wrong. It's on us. We're the experts, we're the leaders in our organization. We have to inform, we have to help make change. With that, I'd like to transition for a few minutes and talk about one of the things I really love a lot is pediatric vascular access. This year, I was excited to see a publication by Mary Beth Davis, Darcy Dolman, and myself hit the JAVA journal. This publication is a position paper that is also available on AVA's website under the position paper tab. And I will say this is an opportunity where COVID gave us a little bit of extra time to think and reflect and provide you with additional resources. We published the minimum education and training on pediatric and neonatal IV clinicians for all clinicians. And we took the extra downtime we had during COVID when we were locked in our homes for a few weeks, and we said, how can we shorten that 17-year cycle that we talked about? How can we help you implement this in your institution faster? So we created the checklist, and it's part of the publication. I was really excited when I sent this to my hospital and to all my nurse educators and leaders, and they were like, this is awesome, we're implementing this right away into practice. So by having that checklist right at your fingertips, it really helped to shorten the implementation phase of this document. I would encourage you to take a look at this and see if it will fit into your practice as well. I also want to share at the end of this presentation, we have provided 6 QR codes to some of the free downloadable articles that have been presented in this presentation today, and this happens to be one of them. So if you want easy access to get there, there's a QR code at the end of the presentation. I'm also excited to share that I am near the completion of my Doctorate of Nursing Practice program, and my big project is actually to create the computer-based training to support this minimum competency education. So a lot more to come on this topic, but I want you to know that the tools to help provide minimum competency are available to you. And while I think this is really impactful not only for children's hospitals, I often hear from many of you that are in adult facilities that happen to sometimes care for children. This is an amazing tool for you to implement as well to ensure that your care providers that are putting peripheral IVs in children have the minimum competency and the ongoing competency. I'd also like to thank Lynn Hadaway for her presentation yesterday that really emphasized the importance of competency, especially in our space, our field. With that, many of you joined us last night as Trisha at Clyden and Dr. Vineet Chopra presented on Magic and Mini Magic. This publication came out not too long ago. It is also a free resource, and Mini Magic is the appropriateness guidance for intravascular catheters in our infants, neonates, and children. I encourage you to download this into your and read it and help disseminate this information. There's also an app available for Mini Magic where when, I know oftentimes we're challenged with really difficult clinical scenarios, and we can pull out the app and have our collaborative team together and go, you know what, let's see where this scenario will fall within Mini Magic. And we can then take what is provided in Mini Magic, what's happening with that patient's case. We can have a great collaborative discussion on what's the right device with the least amount of risk for our patients. I'd also like to have a short discussion around patient safety and sustainability. Today in healthcare and in our world, there are chemicals that are no longer allowed in children's toys that we actually have in some of our medical devices. As a result, babies born in the US today have over 200 industrial chemicals and pollutants in their bloodstream the day they're born. These early life exposures to phthalates, for example, are linked to later life challenges like asthma, allergies, and cognitive neurodevelopmental problems. While we're just really beginning to understand the challenge with this, I think it's important as a vascular access community that we have an awareness. PVC and its toxic breakdown product, DEHP, can be found throughout our hospitals And when patients are specifically exposed, for example, to cardiopulmonary bypass, feeding bags, ECMO, hemodialysis, infusion administration sets, IV and blood bags, and peritoneal dialysis bags and tubing. As vascular access clinicians, we're often at the table making decisions, and it's important that we understand what's in the products that we're bringing into our organization. This information is brought to you by a case study publication that was recently provided by one of the largest group purchasing organizations in the United States, and it is available for download at the end of this presentation. The transition from in-person to virtual allowed Dave and I a little bit of extra time to be able to incorporate this really important recent publication from EpiNet. EpiNet is a surveillance research group of hospitals in the United States that actually volunteer to provide their sharps, injury, and blood and body fluid data reports. These reports are then publicly shared. As vascular access specialists, we need to be aware because we often have needles in our hands and we're surrounded with blood. In the report, they identified in 2020 that of the bloodborne and infectious disease exposure, the most common to be exposed, 36%, are nurses, followed by our physicians at 33%. 55.9% of injured employees were actually not using a safety device. And almost 50% of all splashes of blood and body fluid were to nurses. Let me expand on that. Of the 49.9%, 89.1% of all blood and body fluid exposures are to the face and head, and only 31% were wearing face PPE, like a mask and protective eyewear. That baffled me a little bit because in 2020, we were wearing masks and goggles at my institution. I think we need to think a little bit more about protecting ourselves as healthcare providers, especially as we stand behind needles and we're exposed to blood. Dave, I'm going to turn it over to you to dive a little bit deeper into that EpiNet data.
Thank you so much, Stephanie, and a well-deserved break on your part. Thanks for the presentation so far. And for me, the polling questions and your previous slide having some numbers, and what would a presentation from an accountant be without a nice little bar chart? So I'm going to take a moment to go through it. It's actually a combination bar chart where we have a bar chart along with a line graph. So just to take a moment to dive into it, the orange bar is what you just highlighted on the previous slide about the percentage of injuries that happen to a nurse. And we can go from 2016 over the 2020, the 36.3%, 2016 was 33.4%, but we can see that trend is ticking up a little bit. Not a huge jump, but certainly going in the wrong direction. The next line to look at is the yellow shaded section. For these are either contaminated or unsure as to whether or not the needle that caused the injury is contaminated. So 95 to 97%, essentially 5 to 7% are uncontaminated. So only 5 to 7% of the needle stick injuries are from an uncontaminated needle. So percentages aren't so good for having another adverse event beyond just the needle stick. And the blue line actually shows the incidence per 100 patients as an average daily census, ADC. So in this instance, this is a positive trend where we're decreasing from 33.7 down to 26.6 in 2020. But what it means overall, and the key takeaway for the nursing leadership on the phone today, on the video presentation, is that if you have an average daily census of around 300 patients, you can expect between 80 and 100 needle stick injuries at your facility during the course of the year. And you talked earlier about what's acceptable or unacceptable. The thing about the precautions we have today and still having that many needle stick injuries, I think that's a problem that also needs to be addressed. So now we stay with the numbers theme and go over to the financial implications of what's happening. And you called it out in the poll that there were some individuals that had the cost concern about that catheter placement. And certainly we want that first attempt to last for the entire duration of care. That would be ideal, avoiding all complications. This is a publication that came out in 2019 from Helm and the team that was actually Ethicon Endosurgery commissioned it using Premier data. And what they found is with an uncomplicated admission with a short peripheral catheter, the cost was right around $7,000, $7,009. On the right side, when a person has extravasation, catheter-related bloodstream infection, or even a minor infiltration, the cost jumps up to around $11,000. The exact number is $10,895. That's a 55% increase in cost. So when we think about that for one patient, that's the average cost. When we think about the cost per catheter, we begin thinking about the cost for the individual widget versus avoiding complications entirely. And certainly, as an accountant, you realize absolutes are very difficult, right? It's impossible to avoid every possible complication. You might have a combative patient that rips out the catheter, but the question is, can we do more? And I think in your earlier part of your presentation, certainly we can. Another piece to highlight is you talked about the documentation piece, and we touched upon the electronic health record. In the coding world, and I'm not sure we have any nurses with prior coding experience on the call, but essentially, if it's not documented, it wasn't done. That's the coding fact. So there's a publication by George Tufik which was just published in 2020 that talks about the incidents where it's underreported for extravasation. So in his facility, I believe it was at Rutgers, they looked at what was happening in the electronic health record and the coding and financial systems versus what was actually happening on the floor. And they found a significant instance where they knew the extravasations were happening, but they weren't making it into the electronic health record, weren't making it into the coding system, therefore not making it into the financial system. So it'd be a pretty neat project to go through and figure out, hey, are we able to look at the incidence of these complications using a retrospective database? And thinking about these costs of the short peripheral catheter, I likened it to a gas pump, the price at the pump for the catheter. So we're looking at the individual widget, the individual short peripheral catheter under $2 per unit. But when we think about the cost of an extravasation, $30,000, $40,000, $50,000 in gross charges, what's the true cost number? And I would argue that we can look at the individual cost of the catheter and then realize if we're able to avoid a small percentage of the extravasations that occur, which is already a low incidence, if we're able to avoid those complications, we would actually end up saving the hospital as well as the entire healthcare system the dollars to treat those patients. Stephanie, I'm going to turn it back over to you for the real world observations.
Thanks, Dave. So as you can see, Dave and I, while we view the healthcare through a slightly different lens, I think one thing that we're always centered on is what's best for patient outcomes. So while we challenge each other quite a bit on the day-to-day basis, we really do align in trying to really work towards a better healthcare system. Dave and I have had a really awesome opportunity to work with a real-world peripheral IV program. And through this, one of the aspects that we have found to be really important is actual real observations, not taking data necessarily from the EMR because we know it's inconsistently reported, but to actually watch and follow peripheral IV catheters from the beginning of life until they're discontinued. And there's been some common threads that have really been, I guess, screaming at us. They've just been really evident. One is organizations have no idea what the peripheral IV catheter dwell times even are. And that's unfortunate because with small adjustments, there's opportunity for improvement there. Not only that, as Dave would say, is there's significant cost implications as well. Another aspect in our real world observations is that first stick success, as all of you identified in the survey poll, isn't even being monitored. Our patients are suffering as a result. If we're not monitoring it, we're not working to improve it. Another aspect that's been really a standout, and actually I think most of you might be somewhat appalled, is compliance to healthcare policy related to hand hygiene. And that may seem funny to be in a peripheral IV catheter real world observation, but it's one of the first things that we're supposed to do as we enter a room to care for a patient. And when we talk about and reflect on ECRI's infection reporting of those events at 22%, when we identify in some organizations compliance to hand hygiene less than 15%, we begin to understand where some of the problem may lie in our own hands. The use of vein visualization, not only as we talked about from our surveys, but as we observe in the real world, has a lot of opportunity for improvement. While I know myself as a vascular access clinician, I feel blind without visualization. I don't know the last time I actually stuck an IV in a patient without the use of technology. It has helped improve my first stick success tremendously. And we have huge opportunity in as we look at real world observations to bring that technology to every clinician that has an IV in their hand. Lastly, peripheral IV improvement initiatives often take the back seat to those publicly reported complications. And it's time that we draw the line and stop that. We have a huge opportunity to improve care, to work towards improving patient satisfaction, and to reduce overall complications to our patients if we would only focus on peripheral IV improvement initiatives in our organization. With that, Dave, I'm going to turn it back to you to share just a small glimpse of some of the data that's come out of some of our real world observations.
Thank you, Stephanie. And the slide build just looks awesome there. So these are early results from our real world evidence generation program. And you can also consider it a quality improvement program. This is a sample of our initial 30 inpatient observations. So the program looks at both inpatients and outpatients, but for the focus of dwell time and looking at the entire episode of care, we focused on the inpatients only. So on the left side, we can see that around 74% is our first attempt success rate outside of the AC. On the right side, we're at 84%. So 10% improvement, looking at that, which is an absolute, 10% is the absolute rate. It's around a 14% improvement on a percentage basis. But we look at that chart and look at the fulcrum in the middle. Is it better to have the first attempt success rate outside of the AC be lower, or is having it in the AC, hey, 10% is better, 84%? And I would love to have a polling question with this one, just to see how it comes out. But as we go to the next slide, we have the answer for us. And as we look at these slides and thinking about it from the financial side, right? So we want to have one catheter for the entire episode of care without a complication. I said earlier, virtually impossible to avoid all complications, but if we can avoid a few, we're going to help the healthcare system be more effective in how they're spending the dollars. So as we're looking at the dwell time for these patients, 1.7 days for a patient that had the higher first attempt success rate in the AC. Outside of the AC in the forearm, looking at a 3.8 day dwell time. Stephanie highlighted it a bit earlier about the overall length of stay. When we're getting that 4 to 5 day length of stay, here we have an instance of 3.8 days. We're getting pretty close to that one catheter for the entire duration of care. So a little note says that there, a high first attempt success rate in the wrong location appears to have an adverse effect on dwell times. We are going to continue to gather our data in the real world observations and looking forward and sharing that in the future. Stephanie, back over to you for the patient perspective and certainly the calls to action.
Dave, thank you so much. Sorry for the slide bounce there. You know, I think as we share all of these statistics and information, it's a ton to digest. And what centers me in my practice and in my work is the patient and the impact of what we do on our patients. And one of our colleagues, the new Dr. Linda Kelly, shared with all of us in our Vascular Access Facebook group her dissertation. And the title of her paper honestly kind of knocked me off my feet. It was Pinholes in My Arms. And her work centered around patient perspective related actually to their central vascular access devices. But I couldn't help but apply it here to peripheral IVs. And that's probably because oftentimes when I get called to care for a patient, all I see are the pinholes in their arms. And I'd like to take you back to when ECRI announced their top 10 patient safety concerns for this year. They had a webinar to launch that. And in the webinar, the experts that presented the material, they presented all the content similar to what I shared with you today. And in the Q&A, I asked them, one of the key leaders on that group, I said, why peripheral IVs? And her response was really personal to me. And her response was, our patients are judging their care on their overall IV experience. At the time of that webinar, I was walking side by side with my mom through her cancer journey, where every few weeks she would have to go to one of the most renowned cancer institutions in the world with some of the best doctors providing the best medication and care. And when she would come home, her reflection of that was simply based on her IV experience. If we don't recognize that as vascular access specialists, I'm afraid no one will. But we have to be real and honest with ourselves that oftentimes patients and families judge their overall care based on that IV experience. I do think Albert Einstein said it best. Insanity is doing the same thing over and over again and expecting different results. I go back to that timeline of attempts back to 1998 when I graduated nursing school, and we've not seen significant improvement. So I have 3 call to actions for you today. Number 1, we cannot improve what we aren't measuring. Just like every day I get on the scale, we have to begin to measure what's happening with our peripheral IV catheters. We have to identify why our catheters are failing. Call to action number 2, we have to drive initiatives to eliminate blind sticks. It's time. We've got the support in the standards of practice and position papers by 2 leading professional organizations to help our plea with our organization to update our policies. The time is now. It's up to us to shorten the 17-year cycle. The last call to action that I have for each of you is related to education, training, and competency related to peripheral IV catheters. We talked briefly about the lack of education and training, not only in schools, but in our hospitals. We have huge opportunity to improve not only the onboarding, but ongoing competency related to peripheral IV catheters. I think together, if we can address these 3 call to actions and we can help drive change in our organization, we may begin to see significant improvements in peripheral IV catheter care and how our patients perceive that care in our organizations. As promised, I have provided the references that are free to download. They're in this presentation, which is also available in the AVA Virtual platform. You can go into the slide notes and come back here and you can snap these QR codes. We provide these references for the ECRI Top 10 Patient Safety List, the position paper on vascular visualization technology, Mini Magic, these are all free downloads, as well as the pediatric position paper on the minimum competency and the checklist, and the Vizient case study related to the safety of medical devices. With that, I cannot thank you enough for being here today. And Judy, I'll turn it back over to you to begin the question session.
Stephanie and Dave, wow, that was an amazing presentation. And the information you shared is just incredible. This now ends the CE portion of our session. And be sure to write down the CE code that you see on the screen. Welcome back. So we had a lot of questions, surprisingly enough. First of all, many of the comments are saying congrats on a wonderful presentation to both of you. So thank you for that. Let's see. Do you have or know of any data or information about PIV programs connected to home health infusion programs? Our institution is at the very beginning of establishing a home infusion program that will fall under the responsibility of our institution's home health RNs.
Judy, and to the participant that provided, that's a really great question. I think, we've presented today and been really focused on what's happening in hospitals. But the home health infusion area is again, just there's such a disparity for education and training as well. There are multiple organizations and various companies that do provide education and training. So I would encourage you to reach out not only to AVA, I believe the AVA Academy has IV training, as well as some of your local supporters as well.
Yep.
Thanks, Steph.
The National Home Infusion Association is probably a resource as well. NHIA, for those thinking about branching out. Certainly from the financial side, as we look at where that patient care is being rendered, moving from the hospital to that home setting, we're trying to figure out that reimbursement landscape as well to figure out, is it most appropriate to have them in the hospital or at home? And the payers will follow that as well. So great question. Thank you.
Thanks. And lastly, AVA launched yesterday ACEs by AVA, which is a competency program methodology that AVA has for ultrasound guided PIVs, and then more programs to come. Now, from Cheryl, we need to capture the true cost of complications, including patient satisfaction and the real cost savings of poor care, or cost of poor care. Sorry, she amended this a little bit. The struggle is to get the C-suite and materials management decision makers that are often a barrier to doing the right thing to understand this. How do you put a cost on patient satisfaction and poor outcomes?
So I'll gladly jump in. Let me jump on that one. So prior to coming over to industry, I had 12 years of hospital finance experience where we had a decision support system inside the hospital. And inside of our hospital, we had a cost accounting system. The best way for this particular question to follow is reach out to your finance partners and find out if they have that cost accounting system inside their hospital. If they're able to look at the patients, and they can look at individual patients, whereas industry we cannot, if they can figure out the cost of rendering care to the patient with a complication versus without, that's certainly an argument that leadership will listen to. So first step, internal, reach out to your finance folks and find out if they have a decision support system.
Yeah, and just my perspective on that, Cheryl, thank you for that question. I think one thing that we didn't actually present today, we will probably soon in the future, is patient satisfaction related specifically to their IV experience is never measured in our patient satisfaction surveys. And that is a component that we are actually looking and measuring in our real world observation program. So more to come on that point, but it's actually a brilliant question and a huge opportunity to continue to understand and improve. So thank you, Cheryl.
Thank you. So Deepan says, great presentation. You mentioned a study released recently, which highlighted the reason for PIVC failure as the device itself. Is that one of the shares that you put up? If not, could you please share the study reference?
Yeah, and I apologize. I verbally mentioned that because I believe it was just launched last week, so it wasn't actually included in my reference list. And I believe it was a Con Ed, so it was like a comment. It was an editorial type component. It was compelling because I think when I read that, I'm challenging all aspects of it, right? Like the industry side and the clinical side, as I sit in both seats. And it's hard to blame the device when we still aren't educating. Our most common inserter of an IV is a nurse. And we still don't have mandatory education in nursing schools today around the most common invasive device that they insert. So I feel like we can't look at this we can't point fingers at any one piece. We all have to have this continuous drive towards improvement. So if Judy may be offline, I can identify who asked that question and we can share the reference to that. I'd be more than happy to share it. It's a great article, but I do feel very strongly that we have to really focus on all aspects of improvement of care.
Thank you. Do you recommend clipping hair on PIV site to improve Tegaderm adherence?
I'll take that. No, just kidding. Sorry.
Dave will be like, how much does the clipper cost? I have to tell you, I know that there are recommendations in the INS standards related to clipping. In my pediatric practice, we often aren't challenged with clipping of hair. Judy, I don't know if you want to address it from your perspective on the adult side.
Absolutely. So if the dressing won't adhere to the skin, then the bugs are going to crawl in. So if they're so furry that you're not going to get an adherent dressing 365 on it, then you need to use clippers, surgical clippers, not scissors or a razor. So yes, 100%.
And that furry is a
Maria-
clinical term, just so I can. Furry is a clinical term?
Yeah, just keep that one in your back pocket. That's free.
All right, thank you.
Maria writes, in reference.
Dave, I was just going to say, Dave, clipping. I don't think clipping is reimbursable. So.
No, it's part of standard of care for the inpatient admission.
Yeah. Maria writes, in reference to AC PIVs, with many patients entering through the ED and many needing CT scan or CTAs to rule out PEs, etc., requiring at least a 20 gauge in the AC, do we place the AC site and then place a second site? So how do we achieve first stick, one stick?
Yeah, it's a really great question. Yeah, do you want to hit it first, Judy, and then I follow? Because I think we all have really strong opinions on this.
I think we do. First of all, just because we've always done it that way doesn't mean we need to continue to. So AC should be a thing of the past. We can also put one a couple centimeters beneath the AC to get action and increase our dwell and have a one stick. So we have to work with the folks in CT, and because they'll call back and say, it's not in your AC. I need a larger gauge, whatever the case may be. So I think it's a communication concern. Steph?
Yeah, and I think, especially as you walk the patient's journey, right? So if you're with that patient that has the IV and the AC and now they're admitted and they're inpatient and they're trying to eat and go to the bathroom and ambulate, there's a lot of challenges there. So I think obviously we need to look at every patient scenario individually and, really challenge current practice, but also what is the best device for that patient for their intended treatment. I think we have to continuously and constantly challenge ourselves with that question.
Excellent. Here is, Joseph writes, if or when a staff member identifies the need to change their PIV practice, but have no idea where to start, what are the first steps?
Yeah, so I think, it depends on where you're seated, but I think one of the first steps that you can take is you're here. You're within a professional organization that has a ton of free resources and the accessibility to some amazing experts. Joseph, my first AVA conference, I was sent to learn to develop a pediatric vascular access team. It allowed me to connect with colleagues all over the United States to kind of learn what was happening in other organizations. So that's one aspect. The other is within your own organization, what resources do you have available to you through education or other key experts at your hospital? Who else is a champion? Who cares about what you're caring about? Lastly, I would say you have industry partners that care to help you as well and may have programs to support you. And I would encourage you to reach out and collaborate across all of these spectrums and educate yourself and expose yourself to different people and different ideas so that you can bring the best possible opportunity to your organization.
And I'd like to go a little further and say I commend any clinician that sees something in their practice that wants to do it better. I think we all want to continue to get better every day. And like Stephanie said, there's programs everywhere. AVA, I'm sure INS, each of the companies as well. So, great question. So Frank writes, how do you compel massive electronic healthcare record vendors like Epic to run reports that could give data such as failure rates, failure reason, complication rates, and line days? I often feel like a Dickinson orphan trying to get Epic to give me the reports without a response of Epic is functioning optimally. I feel like VAD data should have its own dashboard.
You know what? This is a topic that we heard last night echoed as well. I know a question came through to Dr. Chopra on this. And while our EMRs have done a great job to get us to a little better level of transparency with information, we have a long way to go. I know I don't work in Epic, I work in a different system, and our reporting is it's pretty minimal. So while we've moved to the EMR, we have huge opportunity to work with our EMR companies, Epic, Cerner, Meditech, to continue to advance the reporting, the mandatory fields, et cetera. And I think the other piece of that is it's also quite fascinating to me how every hospital, even like for peripheral IV, since that's our specific topic, they actually chart completely different things. It really shouldn't be that different. So while the EMR is in existence, in conclusion, we still have huge strides to make in that space. And Judy, it does seem to be a little bit of a trend in the questions that are coming through this year at the conference.
And I think that might even be something we look at is standardization of charting that we can recommend.
Yeah, I would look at local first to find out if the individual facility has a person that's querying the electronic health record. Sometimes they have an in-house person that's looking at it before it goes out national. Obviously, Epic has their own reporting system for all of the users that they report data from, but I would start local first and find out if they have someone in-house that they would be able to pull reports from.
Thank you. Anne says, you've mentioned the lack of education to nursing students in regards to PIVs. Do you recommend teaching students PIV insertion with visualization technology?
Judy and I are kind of laughing about this because we've been doing quite a bit of work around providing education to healthcare students. I think teaching students is multitude. I think we have to teach them the basics. And we also have an opportunity to teach them the use of visualization. And do I think the future is that every clinician will hold an ultrasound probe? I don't know that I'm going to see that in my lifetime, because I think that's a skill that is quite difficult, to be honest. But I think there are opportunities for visualization technology that have been proven to improve visualization and first stick success. And I do think especially students and our newer clinicians need to be using those tools.
I agree. And I think initially they need to learn the landmark way, because that's what they'll see. But like you, I believe in no blind sticks. And I did mention that AVA just launched its ACES program, and that is applicable for students too. And that is ultrasound guided. Okay, we have one more. I've been told hospitals are able to choose which questions are placed on their Press Ganey surveys. If true, does Press Ganey offer the question on patient satisfaction with PIVCs? Dave, you might know that.
Yeah, so they can have standardized questions or individual questions for the hospital. That the one for me on the Press Ganey is those standardized questions. It doesn't always go down to the depth that's needed, and it ends up becoming a free form text that the patient had the adverse experience, writes a little note at the back end that gets summarized in. Certainly, the patient experience is a big part of it. The Press Ganey scores are something that drives the leadership of the hospital. I think figuring out the individual patient and having them come in and talk to leadership would be great, but that they don't always have that ability.
Darn, can you fix it?
Put that on the list.
Okay, good. Thank you. Well, folks, this ends the session for today. Thank you so much for joining it. It was a great discussion. Panelists, you were amazing. We now have a short break. Visit the Exhibitor Resource Center and play a Scan and Win game. And then I'll meet you back here at 12 noon Eastern. Thanks, everybody. Bye.
Thank you.